I need to put in your brain what you need to keep you safe in a family practice with regard to peds. You'll learn a lot on the job. And I need to make sure that you get what you'll need for your exam. And I'm going to do both. What I want to do is let you use a lot of the principles on the job, and I need to make sure that you get what you'll need for your exam, and I'm going to do both. What I want to do is let you use a lot of the principles and the things that you learned about adults as we talk about peds. However, as you recognize clearly, peds are not little adults. They're very, very different. If you had to compare a pediatric patient to an adult, I think the adult you'd have to compare him to would be an elderly adult, just because of the immaturity and a lot of the systems that they have. So we're going to follow these peds as we go through, and you'll see how I have it organized. We're going to start with the newborn assessment. There's a lot of information here, a lot of things. You know, when you take on the responsibility of assessing a newborn, you always have to be on the lookout for something that's a chromosomal abnormality. You're always looking for something that was not quite what you expected to find. And this is what makes it difficult. That baby can't tell you anything verbally. So you really have to have good management of assessment. You need to have really strong assessment skills to take care of newborns and pick up what you have to pick up. So we're going to spend some time talking about that. And then again, when you find abnormals, sometimes it's just a variation of normal. But sometimes those abnormals that you find, especially in conjunction with other abnormals that you find, represent some type of syndrome that baby may have. We need to talk about nutrition, and we will. We're going to talk about children specifically. And AAP, the American Academy of Pediatrics, designates or describes a child as someone between the ages of 1 and 10. You might be surprised to find that AAP says that someone is an adolescent from 11 all the way up to age 21 years. So sometimes you get 20-year-olds who come in, if you work in a pediatric practice, and then you're kind of looking at them and thinking, you need to see somebody else. But anyway, all the way up to age 21. After we do that, we are going to take a break. We'll talk about immunizations, and then we're going to take our last part of peds. All right? So hang with me. Let's get started with this part. The first thing you need to do when you assess a newborn is maybe not even look at the baby first. You've got to get a good history, and we want to know history about mom. I want to know how the pregnancy went. Was this a full-term infant? How did the labor go? What drugs might she have gotten during labor? And again, how did the delivery go? What about mom's past pregnancies? What happened with them? Did she have any other babies that had genetic problems, chromosomal problems? Is there anything in her past pregnancies that would clue me into something to look for in this baby that I'm about to examine? I also want to know about mom's illnesses. Like, did mom have rubella? Did mom have, is there anything that mom had that I need to know about? And what meds was mom on? Like, suppose mom was on an SSRI. I'm going to pay attention to the pulmonary system of my newborn. Lots of things like that will help you. So getting a really good history from mom is going to help you know what to look for in that newborn. So typically we do those newborn visits right there, right at that time. But babies come back to see you 2 to 3 days after birth. And those are those postpartum visits we'll talk about. It is amazing. Maybe you can appreciate this, or maybe you'll have never heard of this before. But I can't tell you how many people have come to see me at 2 to 3 days without the baby. They come without the baby. I'm like, where's your baby? At home. You didn't bring your baby? No. Was I supposed to? Yeah. This is a visit about your baby. So it happens more often than you think. So that's something you need to clarify. But you usually get them again. Assess them at 2 to 3 days when they come in to see you. That's a time we often see jaundice. So you can examine them for that and exhibit. We want to know how mom is feeding her baby. Is she breastfeeding? And if she is, how is that going? You need to find out and weigh that baby. When you compare the birth weight to the birth weight today at 2 or 3 days, what happened to the weight? Up or down? It went down, right? It is not unusual for newborns to lose about 10% of their birth weight in that first few days, and then they begin to gain it back very, very quickly. We're going to look and see the status of the newborn screenings. We don't always get those results in the hospital or at home if it's a home birth. We don't always get those right away. You need to look and see what was done and what do you have results on and what are you still missing results on. So you're always going to review those newborn screenings. You want to know how mom is doing. And then finally, there's a lot that she is going to ask you about care of her baby. Is it okay if the baby has makes a noise when she sucks? Is the baby... They ask you lots and lots of questions. So it's a good opportunity for us to do a lot of teaching. Generally, at a week of age, they come again. And this time you tell them, look, make sure you bring the baby this time. So they come back at about a week. What we want to do is make sure that that baby is gaining weight appropriately. They always get weighed again. We want to find out about their sleep and wake cycles and how often they're going to the bathroom or to have stools. What do those stools look like? We want to encourage her about breastfeeding, especially if she's having difficulty. And then you want to observe how the parent is attached to the baby. What's the interaction between the two? And very, very important, especially when mom has any other psychiatric illness. It's very important to observe for that baby-mother bond. And so you'll do that. If you haven't gotten all the results of your screenings, it's time to make sure you get on the phone and say, how come I don't have them? One of the things you need to make sure that you've gotten by now is results of the hearing test. And certainly any of the metabolic screenings like a PKU or any of them that you did not get when she came back at 2 to 3 days, you need to make sure that you get now. And if you don't have them, you need to find out why. All right? So this is the time we review all of that. Look at my question. Fetal nutrition is best determined by assessing what? What do you assess to say that this baby is getting adequate nutrition? It's not just the weight. What do we look at? Look at number 3. We look at the sub-Q fat on the anterior thighs and the gluteal region. That's what you look at to assess proper nutrition in these new babies. All right, look at my picture. What is that? Milia, right? That's what we call those little things, milia. It's very, very common, and moms worry a lot about that. They'll ask you, what is that? What happened? Look at this picture. What is this? Mongolian spots. They're very, very common. I want you to look at the color of the skin of this baby. We see Mongolian spots way more common in babies with dark skin, and so be on the lookout for that. And then what do we see here? What do we call those? We call it stark bites. Another name is Neva simplex, right? Neva simplex is another name for stark bites, and a common place is on the back of the neck and the upper back. All right, so we'll see that very commonly. These are all things that parents want to know, what is this on my baby? Here's one that we see a little less commonly, but when you see this, parents are going to be very, very concerned, and you can understand why. It's a port wine stain, and typically we see it on the face, sometimes the neck, but the face is a place we see it more often. Anytime there's a concern or a question in your mind about what something is, derm gets them. Derm will do a biopsy if they don't recognize it on sight. A lot of these get biopsied anyway, just so they can make sure that they get an accurate or a diagnosis right at the beginning. Things look different on different color skins, and things look very different just because they always do. Remember I told you yesterday that derm would be one of the last things to come along for you, even in newborns where there's not going to be a whole lot of things they can have. So anyway, port wine stain, again, very common, and also derm would get this because the parents are going to want to know, what can we do to lighten that up? And they can get some interventions going. So anyway, that's what we have. I've given you some more information on these, just some definitions, since I know you don't have the pictures in your book. But again, this information about milia and Mongolian spots, etc., will give you what you need to know. So skin is something we usually look at first because it's just right there to see. What about the fontanelles? The fontanelles are going to be one of the earliest things that you check. How's a fontanelle normally described? Soft and flat, right? Typically, fontanelles are soft and flat, number 2. And so take a look at the fontanelles. What I'll look at is the anterior fontanelle. That's the one I always check first. That one should be open at birth. And it should not close before what? When did anterior fontanelles typically close? What age range? 9 to 18 months is an acceptable time for the anterior fontanelle to close. Tell me about the posterior fontanelle. Is it always open at birth? No. Is that okay? Yes. If the posterior fontanelle is open at birth, when does it usually close? By about 2 months of age. So it usually closes early. The posterior fontanelle is not one most people ever worry about. The anterior fontanelle is one that we worry about. If that closes prior to 9 months or 8 months, what are you worried about? You're worried about growth of that brain, right? The brain grows faster than the bones in your head when you're a newborn. Consequently, that opening will help accommodate that rapid brain growth. What about the eyes? When you examine a newborn, spacing is one of the things that you can look at. There's a word I think you should be familiar with, and it's called hypertelorism. What does that mean? The eyes are far apart. A lot of syndromes have as a characteristic hypertelorism, and consequently, that's one of the things we look for. The cornea is something else that we check. Sometimes if the cornea is enlarged, we think of something like glaucoma. And then you're going to look at the sclera, you're going to look at the conjunctiva. Sometimes the eyes are swollen, you know. And look, see how these little eyes are swollen? And so it's a little bit harder to assess them. But again, eyes, very, very important. Something that you will check from the time they are born until forever is a red reflex. Red reflexes are always supposed to be present bilaterally at birth. And if you look at this picture, you can see that the baby's got bilateral red reflexes, which is always comforting to find. The ears are very important to assess. And of course, they're going to get a hearing test. But what we look for is placement of the ears on the head. Because if the ears are low placed, we often think of things like chromosomal abnormalities. What's the most common one? Down syndrome, trisomy 21, exactly. The other thing I want you to realize is that if there's an issue with the ears, there may also be an issue with the kidneys. And here's why. During embryologic development, the ears and the kidneys develop at the same time. If there was an issue during that time frame, then we may get issues with both. We can't see the kidneys, but we can see the eyes. The ears, rather. So anyway, ears ought to be a trigger, not just for hearing and ear problems, but renal problems as well. I mentioned hearing. That's going to be the results that you want to make sure you follow up on when these babies come back for their visits. What we typically do in all places in the United States, because AAP recommends universal screening, that means every single newborn baby, we use EOAE, and it's evoked otoacoustic emission testing. It helps us know whether or not sound is getting in, and these babies have the potential to hear. If they can't hear, it's going to drastically affect their ability to learn. And so we need to know from the get-go what's going on. In fact, AAP says if you identify a hearing problem in a newborn, you should have interventions in place by 6 months at the latest, because you learn so much from hearing. What about the face? Well, certainly you're going to look at the face for symmetry, you're going to look at the nose, you're going to look at the mouth, and you look inside the mouth. It's not unusual to find natal teeth. What are natal teeth? The baby's born with a tooth. Is that good or bad? It sometimes represents a choking hazard, so often those get pulled, especially if they're loose. We just don't want that going on. The neck is something I really want you to examine. There's a lot to see in the neck that may trigger you to look for something else later on. What is torticollis, by the way? It's a shortening of the sternocleidomastoid muscle. If your sternocleidomastoid muscle is shortened, look what can happen. Your neck gets pulled to the side. The issue with that is that it can affect and impair vision. So we identify torticollis, and if that's present, we usually can get those children into PT, and they can really help reestablish normal range of motion with that neck. So torticollis is something to look for. The implications down the road can be vision. We look for a thyroglossal duct cyst. You don't find this very often. We just found one in a patient just a few months ago, but let me make sure you understand. It's not so unusual to see it in infants. It's going to be right here, right under the chin. However, when you find it in an adult, anybody our age, it's got a pretty high association with what? Thyroid cancer, exactly. So when we find this, it's one of the things that we'll assess for in infants. And speaking of necks, one of the things that we look for is a webbed neck. A webbed neck may be associated with what? Turner syndrome, exactly. I want you to take a look at what it looks like. Look at like the extra skin. We call it redundant skin in the posterior neck. You see it? That is a webbed neck. And that may be a clue that there's some syndrome, a chromosomal abnormality going on with this baby. So that's the redundant skin that we talk about. And look at the ear. You see it? And so anyway, take a look. What about the trunk? You can see that we are progressing down the baby. The trunk has a lot of things to look at. One of the first things I usually check is the clavicles. I check both of them. It's really important in a macrosomic infant. Sometimes those clavicles are broken to get that infant out, or that fetus out. And so what do we do with a broken clavicle? We just have mom move that infant as a single unit, all right? So you don't leave an arm over here and just like, they need to be moved. The crack or the break in the clavicle will fill in very nicely. As it fills in a few weeks, you'll be able to feel a little bump where the calcium is beginning to be deposited. And then over time, it smooths out. So broken clavicles don't represent a huge thing, but have you ever had a broken bone? It doesn't feel very good. So we want to make sure that we move these babies very, very carefully. On the chest, we want to certainly make sure that there's symmetrical movement. We're going to look at the breasts, and we're going to look for supernumerary nipples. What are those? They could occur along the posterior lateral. And they look like little nipples. A lot of times you'll find them bilaterally. Sometimes they're present unilaterally. But again, it's something we look for and see. I'm always going to listen to the lungs, and you know that the respiratory rate can be very, very high in these little newborns. So can the heart rate. There are a couple of things, we'll talk about it a little more in detail later, but almost every one of these newborns and week-old babies is going to have a murmur. Just because it's an immature heart, things haven't entirely closed up yet, so murmurs typically are universal. The femoral pulse is always something you're going to check bilaterally. And what are you looking for with femoral pulses? What problem? It's the most common cardiac anomaly that we see. It is not murmurs. What is it? Coarctation of the aorta. We'll talk a little bit more about it, but that's the purpose for assessing femoral pulses. What about the abdomen? The abdomen has, several things that we're going to look at. One is that you're going to check how that cord is doing. All right, you'll check the status of the cord. Sometimes it's fallen off. Sometimes it hasn't fallen off and it just kind of continues to ooze a little bit. That might be a time for you to take your silver nitrate stick, right, and use it as a cauterizing agent, and it really just cleans it up and helps that thing fall off. So we'll look for that. Distension is never, ever normal, not in a newborn, not in a 92-year-old. So we always assess for distension and gas. And then the genitalia is something I always find, I guess interesting is the right word. It's amazing how many of these newborn reports that you get from the hospital when they send over the records or the home. And it says genitalia female infant, within normal limits, WNL, within normal limits. And when I check, it's amazing how many have an impatent vagina or an impatent rectum, hopefully not by a week. Oh my God, right? So you're checking that and you're thinking, I'm convinced that WNL doesn't mean within normal limits. I'm convinced that WNL means we never looked. That's really what I think it means. So anyway, please check it. If somebody else checked it and wrote it down, it doesn't mean they really did it. So again, males, you got to check the testes, the scrotum. You want to make sure that you can palpate two testicles and assess them, the foreskin, etc. What about transillumination? We referred to it yesterday. I told you transillumination of the scrotum. Why do we use that? What does it do? It can differentiate a hernia from hydrocele. So here's what might happen. The male infant's scrotum may be swollen, and that's not uncommon. Is it swollen because there is a solid mass in there, like a hernia, a loop of bowel, or is it swollen because of fluid, a hydrocele? A light will help transilluminate it. Fluid, glows. If the enlargement in the scrotum is from a mass, it does not glow. So that's the purpose of transillumination. Number fluid, a hydrocele. A light will help transilluminate it. Fluid, glows. If the enlargement in the scrotum is from a mass, it does not glow. So that's the purpose of transillumination. What about the trunk and spine? You always have to turn the baby over. You're going to count and you're going to palpate every vertebra. And we're looking for a neural tube defect. One of the things that we find, and you don't find these that often, so I got a picture and I want to show it to you. Here's an example of a neural tube defect. You see it? Right there. So a common place to find it is there. A lot of these are occult. It'll be an occult spina bifida and you may miss it, but again, we always check for that, especially if mom had late preterm prenatal care, probably didn't get enough folic acid, always one of those things we look for. With the extremities, that's always a fun thing to look, because if you put your finger in the palm of the hand of a newborn, what should they do? They grasp it right away, and you'll see that up here, no matter how little they are. You see it? So I count fingers, I count toes. You have to make sure that they have spontaneous movement. If there's asymmetrical movement, what are you thinking of? You can think of a broken clavicle, maybe. You can think of, there are all sorts, a birth injury, a brachial plexus injury. There are all sorts of things that can happen. So symmetrical movement is very important to assess, all right? And that's one of the things you'll do. We'll talk some more about developmental dysplasia of the hip, but obviously that's going to be what you will do, all right? We always check that, and we're going to check it for a while. If I wanted to assess you neurologically, I'd probably go up to you and say, hey, where'd you go to school? When do you think you're going to take your exam? Do you have a job lined up yet? And depending on the answers you gave me, I would say, oh, yeah, this guy's ready to take his exam. I'd love to hire him in my clinic. Or I might say, that guy's been in the wrong place for 2.5 days. I can assess you neurologically, but to assess a newborn, I can't ask any of those questions. We assess a newborn neurologically using those primitive reflexes. You might be surprised to find that there are about 72 of them. How many did you have to learn? About 6 or 8, right? And you thought that was a lot. Thankfully, you didn't have to learn all 72. These are the ones that commonly we check for. Just kind of lets us know neurologically this baby is probably hooked up correctly. So we check and assess these. I'm not really aware of a lot of neurologic reflex questions on the exam. But again, I want you to have them here. What about nutrition? Breast milk, if we get to use the word ideal, breast milk is when we get to use our word ideal. Breast milk is ideal for full-term infants up to about 6 months of age if they have no other source of nutrition. Breast milk is a very, very good source. We typically delay complementary foods. What does that mean? Solid foods, right? Until 4 to 6 months, according to the American Academy of Pediatrics. One of the reasons we don't want to introduce solid foods too early is because we risk atopic sensitization. What does that mean? Atopic allergies. Yeah, exactly. Atopic dermatitis. So we don't want to introduce those too early. And typically, a newborn's or an infant's stomach is not ready to go before 4 to 6 months to digest those foods. So what about feeding? How do you introduce those foods? We typically introduce a single ingredient food first, and we often use rice cereal, because rice is the least allergenic of the cereals. Oat, wheat, rice, of those, rice is the least allergenic. That's the one we want to start with, and if that's tolerated well, then we'll introduce another one, and we'll introduce another one, and that's typically how we do it. The deal on fruit juice is this. Kids love it. Once you give a baby or a child or an adult or an older adult something sweet, they love it. That's what they want. We try to withhold fruit juice until about 6 months of age when they can drink out of a cup, right? That's when AAP thinks is the best time to introduce fruit juice. And we never are supposed to give more than 4 to 6 ounces per day. So again, fruit juice, watch out when that's introduced as you coach parents about it. As far as cow's milk, what we generally say is for parents to withhold that until at least a year of age. Prior to that time, again, we risk atopic sensitization. So cow's milk, not until a year. And then I missed finger foods, but children or infants begin to have good hand-mouth coordination about what age? about 6 months of age, right? They really begin to get pretty good at putting stuff in. And that's the time we begin to think about finger foods. Generally 8 to 10 months, they're ready. They can chew, they swallow, they got the whole idea of eating. With regard to supplementation, a couple of things. Iron is often, we usually don't worry about iron until about what time frame? Okay, I would tell you maybe something a little different. With iron, we usually begin to give iron-enriched cereals because we are worried about development of anemia. If they get just milk, there's no iron in milk. So often that's enriched. Cereal is enriched. Meat provides them with a good source of iron usually. If you had to calculate how much they need, it's about 1 milligram per kilogram per day. They usually get adequate amounts in an iron-enriched cereal. Fluoride is one of those things that you need to have a conversation with the parent or the caregiver about. And here's the deal. In a lot of communities, a lot of parents feel like fluoride is a toxin. I don't want my baby to have fluoride. Fluoride is put in some water supplies and not in others. It is not in bottled water. If the caregiver wants that child to have fluoride, and it's not in the water supply where they live, and it is not in the bottled water that maybe they use to make cereal with or whatever they use in, then you need to give it a supplement in their vitamins, right? So ask about that. Now, let me ask you, how do you find out about the fluoride content in the water from your babies? Right. The county or parish is going to have a table, and they'll tell you in this place, this place, this place, this is how many parts per billion fluoride is in the water. That's how you'll be able to determine how much fluoride you need to give them, all right? So if they're not getting it, they probably need to get it for what? Why do we give it to them? The teeth. Yeah, exactly. So anyway, dental health is one of the reasons we use. What about vitamin D? We give vitamin D... vitamin D for exclusively breastfed babies. We always are concerned about that. What about vitamin B12? We think about that in parents who are either vegans, not parents, but the mother, if she's breastfeeding. Strict vegetarians, we think about addition of vitamin B12 in the infant too, if that's the issue. So there's a whole lot with a newborn or in the first week or so to assess. We got advanced nutrition so that they grow. Let's move and talk some more specifically about these areas that we kind of just assessed or the very first time we saw it. I want to go by body system, and I kind of call it essential pediatric assessment. These are things you just need to know, and people don't get so much experience assessing these peds as I think you used to be able to get. So let's talk about it. When you evaluate eyes, I've divided it by the age of the child so you know what to look for. In a newborn to 3-month-old baby, red reflex is always assessed bilaterally. We always look at the eyes. I talked to you about hypertelorism. As children get older, infants get older, 3 to 6 months, one of the things we want to make sure that they can do is fix and follow. We don't expect that in a 1-month-old, but by 3 to 6 months of age, they ought to be able to fix and follow. And that's, in addition to the red reflex, is going to be what you're going to assess when they come in. As they get older, we fix and follow each time. We check for red reflex and we inspect. Now we're looking for corneal light reflex. What is that test called? The Hirschberg, right? We're looking for that as well. Once they get to be older than 3, yeah, I'm still worried about red reflex and all that, but now my focus becomes their vision. How well can they see? And so let's take a look. A 1-week-old infant does not have a red reflex in his right eye. You worried? A lot. What are you thinking about? Why not? What about congenital cataracts? All right, that may be the most common thing that you see, unless you work at a pediatric oncology center. And then what might we see if there's a unilateral red reflex or an absence of a red reflex? Retinoblastoma. It's not very common, but if you work at St. Jude's, you might think, oh yeah, we see that every day. Oh, that's very common. Well, it's common to you, but not common in primary care. But that's one of the things that we're concerned about. I sort of gave you this one. At what age should eye alignment occur? You know, you get those newborns, they're like a month old, and what about their eyes? They're like going all over. Like, when are they supposed to like look at you and not anything else? By 2 to 4 months of age, the eyes should you should be able to track and follow. They should focus on the same object at the same time. Number two, I told you that as children get to be older, we have to be able to check their vision. One of the things that you will always screen for in children, always less than 5 years of age, we look for a loss of vision called amblyopia. But before it gets to that point, there's something we should have picked up. Let me tell you about it. If two eyes don't focus on the same object at the same time, the brain gets two different sets of information. So the brain gets information from that eye and this eye. The brain says, oh, that's just too, I can't take all that. Just give me one set of information. And the brain will negate the information from one eye. The eye that has the information negated in the brain begins to lose its ability to see. That loss of vision is called amblyopia. Look at the last bullet. It says it's the most common cause of vision problems in children. And so, if we can pick this up and get it corrected, these children have good vision. And so take a look. The corneal light reflex and the cover-uncover test are used to assess what? Strabismus. Yeah, you remember the corneal light reflex? You take your pen light and you're going to see if the reflex is in the same place in both eyes. If it is not, you're going to worry. Another test that we use for strabismus is the cover-uncover test. Do you remember about that one? You're going to cover an eye and get something to make the baby look. And they're going to focus, and then you're going to pull this away. If that eye is not focusing on that object like it should be, then that's a red flag. That always gets a referral to ophthalmology. So what are we doing that for? Assessment of strabismus. So those are the two tests that we use. And if either of those is abnormal, it's a red flag. Take a look. Here's a cover-uncover test. We generally start at about 6 months of age, and we continue until we begin to do vision screening. Look at that little eye. You see it? When you do the cover-uncover test, if something is wrong with the eye that is covered, it will have deviated in one direction or the other. Always a red flag for you. When we think about screening for vision, I want you to look at this, but please don't memorize it. Starting at age 3, we should try or attempt to assess vision in a child. How many 3-year-olds are cooperative to do vision? Not a lot. So AAP says, listen, you need to try it at 3 years of age. If the child's just not cooperative and he just wait 6 months and try it again. If at 3.5 years he still is not cooperative, do it at 4 years. The point is, they want you to continue to try. At 3 years of age, what I want you to realize is that children's vision is still not that great. Yours is better than that. A 3-year-old has a vision of about 20/50, which for you means if you're trying to show them a bird in a tree over there, you can about forget it. They're not going to be able to see it. They only see big things if their vision is 20/50. In just a year, by 4 years of age, their vision is a little better. At age 5, it's even better. But by age 6, by the time they go to school, they're in the first grade, their vision ought to be 20/20. I want you to look and see that AAP wants you to screen vision 5, 6, 8, 10, 12, 15, 18. Don't memorize that. They want you to assess it periodically because children grow periodically. And when a child grows, it isn't just their legs and arms that grow. Their eyes grow as well. And the lens of the eye grows too. If there's asymmetrical growth of the eyes, then vision is going to become distorted. So one of the best times to check vision in a child is after they made a growth spurt. You got it? So that's why we assess them periodically. And so I don't know if I'm so wrapped up in the age that we check it, but the point is you have to check it very periodically because during those growth spurts is when we're likely to see a change. Everybody with me on eyes? Really, really important. What about your ears? In a newborn, we assess, probably up to 3 months of age, we assess the startle-Amaro reflex. In the days when we had hard plastic charts, you know, you put the paper in it, I would go in, and this is how to assess Moro. I would go in, and the mama would be there with the baby, and I'd go, bang! And I'd watch for the baby to do like that. If they startled, I knew right away. Hearing is checked, all right? So that's just an easy way to check for that. At 3 to 6 months, when you talk or mom talks to that baby, they ought to stop and listen. That's your indication that they can hear something. At 6 to 12 months, if you say John or Ann or whatever the baby's name is, if they hear it, they ought to stop and they ought to look. So there's some little clues that you can do in your clinic that will help you. What about intelligible speech? That's a question that parents ask me a lot, and they'll say, I understand what he's saying, but nobody else does. Well, how much do you understand? Because typically by 2 years of age, only about half of what they actually say and articulate, you're able to understand. Someone who is not intimate and familiar with that baby. So that's a good rule of thumb. By 2 years of age, about 50% of it should be intelligible to you. All right? Here's what I know. Look, pediatric hearing loss is associated with what abnormality? You know it. Speech delay. Listen, one of the first things you probably noticed about me was my accent. It's different than yours, and yours is different than the person you're sitting next to. You know why? Because you mimicked the sounds that you heard as you grew up. If you can't hear, it's going to be very difficult for you to try to mimic those sounds and articulate them. So I would just remind you that if children can't hear, they're going to have a really difficult time learning to speak. All right? So speech delay, number 3. What's the purpose of pneumatic otoscopy? Have you had a chance to use that? Hopefully you have. What is that about? It assesses mobility of the TM. So here's what happens. Here's the tympanic membrane, all right? When the tympanic membrane gets hit with a puff of air, it is supposed to do this. All right? So here comes a puff of air, it moves. If the tympanic membrane is stiff, we often think it's because there's fluid or pus behind it. So pneumatic otoscopy helps us. Based on the number of people who've never done it before, let me show you an easy way to do it. You know, you have a otoscope with like a little tubing and a little like miniature blood pressure bulb. You know what I'm talking about? That's what we use. That's what creates the air that goes through there. Put the bulb in your 4th and 5th finger like this and hold the otoscope with the first 3. That way, you can hold it like this and you can squeeze the bulb with those fingers. It takes a little bit of practice, but you're going to have to use your other hand to hold the ear, the pinna, so that you can straighten out that canal and see. So it gets to be a little bit of a trick, but use the bulb in your 4th and 5th finger and you'll see with a little bit of practice, it becomes second nature to you. All right? Have y'all had a chance to at least practice with it, play with it? Not too much. That's surprising. All right, so assess TM mobility, number 4. Articulation. Please don't memorize it, but look, 24 months, 25 to 50% minimally should be able to be understood. And then as they get older and older, you should be able to understand more and more of what they say. Don't forget that children are going to have difficult times with certain consonants. G's often sound like T's or D's. Instead of a garbage can, they might say a garbage tan. A garbage tan. And so you'll hear that, and honestly, those are pretty normal, even up to 4 and even up to 5 years of age, all right? What about the mouth? When you assess a baby, and really you assess them at all ages, we're always looking for teeth. Remember the first teeth erupt at about 6 months of age, right? So you begin to see those teeth erupt. If you take care of college-age students, you will still be taking care of people who have teeth that are erupting. I honestly think that you should get more dental information in your coursework than you probably got. How many people work ER? How many tooth problems do you see in a week? Loads of it. So you need a lot more dental information than you have. I would encourage you to, if you have the opportunity to go to one of those primary care dental like updates, you should go. You should go because there's a whole lot about teeth that you need to learn, especially in adult teeth. So anyway, last teeth erupt at about 20 years of age. You need to know a whole lot more than you probably know. When teeth erupt in babies, they typically erupt symmetrically. So you'll see the 2 bottom ones right here. You see them? And we may see the 2 top ones that come out. And they just begin to erupt like popcorn. All right, so throughout. By 2 years of age, that baby should have had most, if not all, of those teeth erupt. Look at this question. The best way to examine the oral cavity of a small child. Do they like opening their mouth and having you stick a wooden, bad-tasting stick in it? Of course not. I wouldn't open my mouth either. So how can you do it? The best way to do it is to lie the child on his back on the exam table. And when you put your tongue depressor in, if you go right in and put it on the top of the tongue, what do you think is going to happen? They're going to bite down because they don't want that thing in there. They're not going to just open up. It's pretty easy to slide it in on the side, put it all the way in the back, and then just kind of twist it. And then you get like a little wedge. And if you stroke the bottom of the mouth, they'll often open right up for you. All right? Another good time to look at the mouth is when they're crying. If something you've done or when you walk in the room they begin to cry, that's when I'll pull my light off and I'll look at the mouth because it's wide open and you can see all you want to see. All right? So that will save you something. So anyway, lie the child on his back and on the exam table. What about the heart? I want you to think about something. When you were born, your heart was the size of a walnut. It was this little. Right now, as an adult, your heart is the size of a fist. So to get from this size to this size, a lot of growing and stretching had to take place. The growing and stretching that took place in your heart as you grew to maturity is what produced turbulent blood flow, which produced murmurs. The reason we hear murmurs so often in children as they grow is because it's turbulent blood flow. The vessels and valves and chambers have to grow and stretch. And when that happens, turbulent blood flow is created and we hear murmurs. Thankfully, most of them are benign. The second thing you have to consider about a heart this little is that it is not very efficient. It's not. A heart this little has got to pump this many times in order to get the work done. As the heart grows and becomes more and more mature, the heart rate begins to come down. So you'll see that. If you think of somebody who is a marathon runner, someone who's very physically fit, their heart rate may go into the 50s or even the upper 40s when they sleep at nighttime. Their heart rate is so darn efficient, it doesn't need to pump 80 times a minute to get the work done. So consider it. Look at this question. What's the purpose of measuring blood pressure in all four extremities in the newborn period? Who's worked newborn nursery? All right. You know you've measured it in all four extremities. You do that in every newborn. Why do you do that? Because you don't believe it in one reading? No. We're assessing for coarctation of the aorta. And so look at number 4. So what's coarctation of the aorta? Coarctation of the aorta means that the aorta is narrowed. It's one of the most common cardiac anomalies we see in children. If your aorta is narrowed, then what we're going to find in you is elevated blood pressure in the upper extremities and diminished blood pressure in the lower extremities. And it is very evident if you check blood pressure in all four extremities. When we get these children in our clinic, we don't typically measure blood pressure in all four extremities again. What we do instead is compare an upper extremity pulse, a brachial, with a femoral. When you see people comparing both femorals, does that get it? No, because they ought to be equal. You have to compare the amplitude of a brachial and a femoral pulse. If there's any question or you just wonder, check blood pressures. Right? You got to have a proper size cuff, though. Right? All right. I know you know it because you just have had these life experiences. But remember that many children with chromosomal abnormalities or some type of gene disorder have heart defect, cardiac defects. And if you think about the ease of identifying them, the little heart is right on the other side of the rib cage. Like that little bitty chest is very little, and the heart is just on the other side of the ribs. It's so easy to hear it. So I want you to listen very, very carefully. March your stethoscope around the chest. It's a whole lot easier to hear these things in an infant than it is in an adult with a barrel chest. You got it? So listen very carefully because you'll be able to pick them up. Now, you might not know what you're listening to. You can always get an echo. You can always get some help. But you got to listen and be alert because many of these chromosomal abnormalities are associated with cardiac issues. What about assessing their heart rate? Did you check a pulse on them? No, we don't do that. Up to age 10 years of age, we assess and count their heart rate with the stethoscope. We use the chest to do that. So we always assess respiratory rate. And when do we start assessing blood pressure? When should routine blood pressure screening begin for children? 3 years of age, right? Number one, at age 3. And again, you have to make sure that you have a table, and you have to make sure that you know the age, the gender, and the height of the child. That's how we determine what their blood pressure ought to be. We determine what the maximum systolic and the maximum diastolic blood pressure should be. But honestly, you almost can never look at a baby or a little child and know what their blood pressure ought to be. You got to get the table. Well, speaking of things that we assess, what about dyslipidemia? Because American Academy of Pediatrics says we all need to begin to do this. And, hey, wait, Amelie, you got an age 2 up there. We start assessing for dyslipidemia at age 2? 2 years? The answer is yes. You mean like with a fasting lipid profile? Of course not. How do we assess for dyslipidemia in a 2-year-old? We find out what they eat, right? When children grow up thinking that a French fry is a vegetable, that probably is a clue that they have dyslipidemia, all right? Or they're going to be at high risk for it. So generally we do this by age 18 to 21. In late adolescence, AAP says this person who doesn't have any other known risk factors should by now have a fasting lipid profile. Remember that coronary artery disease is a disease of accumulation, which means that the earlier we identify it and get it corrected, the better chance we have to make good long-term outcomes happen. When children come in with GI issues, really, we don't just restrict our assessment to the abdomen. The GI system affects everything from head to toe, so you may find yourself assessing all sorts of things. We look at growth. We look at hydration status. We pay particular attention to the abdomen. Remember that the order of your abdominal exam, what do you always do first? We inspect first, right? What do you do next? You auscultate. What happens next? Percussion, and then what? Light palpation, and then deep palpation. So we always inspect first. Make sure you know the order of your abdominal exam. And I think we're pretty good on that. Take a look, because there's some abnormalities in the abdomen that I want you to be alert to and know what to do with. First of all, we often find umbilical hernias, and they're way more common in African Americans, especially up to age 4 or 5 years of age. They're very common in Hispanics as well. When you identify one, let's say it's in a 2-year-old, what you're supposed to do is make sure that it is easily reducible, all right? And what happens is it usually pops right back out. Something that's just like that. I know all of us had this experience when we were a kid. Haven't you, blown up one of those long, skinny balloons? And you blow it up, and you blow it up, and you blow it up, and it just keeps getting longer and longer. What's at the very end? It's that little nipple, right? Well, I know you did what I did when I was a little kid. I would blow up the balloon, and I would put my finger in it, and I would look at my finger in the balloon. Did you do that? And then what happens when you pull your finger out? It shoots back out. That's an umbilical hernia. That is an easily reducible. You've been practicing that for a long time, right? What about hyperbilirubinemia? It's something we always look for on the skin, and we begin assessing right away. When they come in at 2 to 3 days, we are assessing for this. By definition, hyperbilirubinemia means that the bili level is more than 5. And here's why it happens. When each of us was born, we had a very immature liver. Your liver is supposed to chop up bilirubin. Where does bilirubin come from? Inside red blood cells. So when you were born, lots of red blood cells lysed. In other words, they spilled their contents. And one of the things that were spilled was bilirubin. If your liver got more bilirubin than it could chop up, it deposited the rest onto your skin. And that's why babies end up with that golden hue, all right? What we look for when we see that, we often wonder about something going on with the liver or maybe even the gallbladder. It doesn't happen often, but you can't miss this one. So we always assess bili levels. I need to make sure that you know this word that starts with a K. It is kernicterus. Kernicterus is what happens in an infant's brain when Billy levels rise and treatment is not completed. Bilirubin begins to be deposited in the brain, and it results in significant neurologic delay and damage. So kernicterus is one of those things that we always worry about, but honestly we don't see nearly as often as it's talked about. So take a look. The Billy level peaks in full-term infants at about the 3rd or 4th day. In a preemie, it takes almost a week before the Billy level peaks. If you're a newborn nursery nurse, you know what this is. It's called the Butani nomogram, and it usually is on the wall in the newborn nursery. It could be on your lab report, but it's all over. It's easy to see. What this thing will tell you is whether the Billy level that your patient has is good or not. I'll show you how it works in a minute, but look at this question. A 3-day-old term infant who is being breastfed has hyperbilirubinemia. It's 16. First of all, I want to know if 16 is high or low, or what do you think? The baby's 3 days old, so he's 72 hours. His level is 16. So look where he is. He's right here on the Butani nomogram. So he's high. All right? So the baby's Billy level is elevated. How is this most often treated? How about phototherapy? Exactly. What do we do about breastfeeding? Continue the breastfeeding. Exactly. Keep them well hydrated, and they usually do pretty well. What about musculoskeletal assessment? Man, there are a lot of things to assess in these children, huh? There's a whole lot. And you really got to be a good assessor to pick up those things so that you don't miss something. With the musculoskeletal system, one of the things that we are clued in on is developmental dysplasia of the hip. And honestly, it doesn't happen that often, but when you have a baby with it, you got to nail your diagnosis. There are 2 tests that I think you should be familiar with because they're quick, cheap, non-invasive, and you can do them in your office. There are 2 tests I think you may see again because they are quick, cheap, non-invasive, and you can do them in your office. And that happens to be Barlow's and Ortolani's test. So take a look and I'll show you a picture. Where should the examiner's 2nd through 5th fingers be placed to perform Ortolani's test? Where do we put them? On the greater trochanter. Take a look. Well, first of all, pediatric ortho-resident? Size of the hands? Yes. Pediatric ortho-resident, right? So his fingers are really so big. He could probably do this with 2 fingers. But you put the 2nd through 5th fingers right over the greater trochanter. And what you're going to do is this. So you lie them on their back. You put your 2nd through 5th fingers right over the greater trochanter. And you're going to internally rotate the hip. When you internally rotate the hip, if they have a hip dysplasia, the femoral head will be dislocated toward the B butt, and that's B Barlow's. All right, so 2nd through 5th fingers go over the greater trochanter. Internally rotate the hip. That's Barlow's test, and I remember because I kind of envision the femoral head. If that can be dislocated toward the B butt, then that's Barlow's. Don't move your fingers. I want you to externally rotate the hips. Look at the picture. When you externally rotate the hip, there's a potential that that femoral head will click or clunk. And that's what you're listening and feeling for. That test is Ortolani's. So you're listening for a click, and I've never heard a click where I couldn't also feel the clunk. All right, or the little, and you'll know what it is. Next question, once you feel that, what's your job? It depends on where you are. Yes, you'll refer. Some people want x-rays right there. They'll say, look, let's do frog legs. Let's do weight bearing. Some places who have good ultrasonographers will want to assess those hips under ultrasound. I don't know if you realize it, but ultrasound is a good way to look at a joint if you've got an ultrasonographer who's really good. All right, so in some places you'll see ultrasound. Some will do x-rays. In any event, you're going to get this patient referred to pediortho, and they'll figure out what to do with them. So here's another clue. A 2-month-old patient has suspected hip dysplasia. What might be present on assessment? What are you thinking? Well, they often have, and I want you to know this word, they have a positive Galeazzi test. Take a look. They have unequal knee heights. You see it? So you lie the baby on his back. You put both feet, the soles of the feet, flat on your exam table with the knees bent. I want you to observe the heights of knees. When they have unequal knee heights, that's a positive Galeazzi. That's dysplasia until proven otherwise. All right? So that's another test that we have. When we think about feet, there are at least a couple of things we pay attention to. One is a club foot. It is an urgent orthopedic referral. Talipes equinovarus is the name of that. What are you supposed to do when you see that? If you're doing your newborn nursery exams, because that's what you do, it is an urgent orthopedic referral. What does ortho come in and do with these babies? They tape them or they cast them, depending on where you work, and they prepare for surgery at some point. But they tape or cast them often before they leave the newborn nursery. So you'll see that, but not nearly as common as metatarsus adductus. Look at metatarsus adductus. Look at the picture. One thing that we look for is an in-toeing. And an easy place to see that is by observing the arch of the foot. Now listen, when you observe or you look for metatarsus adductus, you got to make sure that the perspective you have is that you're looking at the soles of the feet. What I don't want you to do is have the soles of the feet right here and you're looking at them this way. You got it? You need to make sure that when you look at them, you're looking at the bottom of their feet. Because what you're looking for is in-toeing. You see it? So you're looking for in-toeing. The next thing you do is you need to make sure that you can move both of those feet to midline. If you're able to move both feet to midline, we describe that as a, what do we call it? A flexible metatarsus. A flexible metatarsus means that you can keep those people. So if both feet are in-toed, you want to make sure that you can move them to midline. If you can move those feet to midline, it is considered to be a flexible metatarsus. The instructions you'll give the caregiver are to move the feet to midline 10 times every time they change the diaper. All right? If the feet are in-toed and you are not able to move one of those feet to midline, it is considered a rigid metatarsus, and a rigid metatarsus always gets sent to pediortho. All right, so if it's a rigid metatarsus, meaning you cannot move the foot to midline, that always gets sent to pediortho. So what about that? What might that be? It might be an incomplete club foot. Something's going on. So let someone assess that so that that child has a potential to walk normally as he grows. All right? A question I get often from parents is, do you think my baby's bow-legged? And here's what you need to remember, and I remind this to parents. Children's legs and the alignment of them is typically determined by the hip, and it changes as they age. So it's not unusual in a newborn, like this 6-month-old, to look like he's got bow legs. Then he looks pretty good at about 1.5 years after he started walking, and then by 4 years it is not unusual to have someone who's got knees that begin to touch, right? And then finally, they grow as their hip grows, and you begin to get alignment of the legs in young adults and adults. So that's a common question that parents come in and ask you, but this is a normal progression in the lower extremities. The musculoskeletal assessment always involves the spine, and one of the spines, or the ages where we worry about spines, is in adolescence and pre-adolescence. What we look for is scoliosis. By definition, scoliosis means a 10-degree curvature of the spine or more. And the test that we use to assess it, or one of them, is called the Adams Forward Bend Test. So you have your patient lean over, and you're going to assess for scoliosis in the spine as she bends over, and you can see it in the picture. And so what you will order, the test that you order, could be one of two things. You could say, oh yeah, scoliosis series, and send that over. The other option that you have, and really they'll give you the same information, is you'll order a full-length PA and lateral with the patient standing. The reason you order a PA as opposed to an AP, so you get the x-ray from the posterior, anterior, as opposed to anterior to posterior. Why do you do that? Thyroid gland. It's radiation, right? So you're preventing radiation, or it minimizes radiation to the breasts in both men and women, and also the thyroid gland. So when you order it, that's what you'll order. Now, you don't need to know this, but you'll see this on your X-ray report. The radiologist is going to describe something that he uses or she uses to measure the angle. And they use something called the Cobb method. And the Cobb method, again, measures the angle of the spine based on this little lines that they imagine, these imaginary lines that they draw. You don't need to know it, but in your report you'll see the Cobb method was used to assess the degree of curvature in the spine, and this is what it showed. So anyway, that's what the Cobb method is. That's what that means. Before we leave scoliosis, I need to know that you know about this. Which scoliosis patient should cause the greatest concern for the NP?
Yeah.
Who is it?
Watching the video.
Well, by a process of elimination, I'm most worried about the 2 with the 20-degree curve versus 15. That leaves me with number 1 and number 2. The question is, am I more worried about a 13-year-old or a 17-year-old with a 20-degree curvature? I'm much more worried about the 13-year-old. How come? The 13-year-old has probably just begun her growth spurt, and the curvature is going to worsen as she grows. I'm worried about the 17-year-old, but the 17-year-old is probably near the end of her growth spurt, and I don't expect the curvature to get a whole lot worse. So number 1, I think, is your best answer. What about the GU eval? So we're looking at kidneys, and one way that we assess kidneys is by measuring blood pressure. You'll always do that. We look for edema. We hate to find edema in the lower legs, especially in an infant or a young child. Again, we look for ear position. We look for abdominal masses. CVA tenderness might trigger what? A diagnosis of, make you think about what? Pyelonephritis, yeah, exactly. All right, and you may assess, too, if you're doing a GU eval, to get a UA in these children. What about Tanner staging? Is that on your list of things like you're not learning, you don't care if you miss it? How many people have Tanner staging on their list of things I'm not learning, that if they ask me, I'll just miss it? All right, listen. There are a couple of ways I think it may straighten this out in your brain. This is the way I think of it. I know that Tanner staging has 5 stages in an adult. A stage 1 was you at 4 years of age, completely immature whoever. A stage 5 is you right now. Stage 2, 3, and 4 represents one more stage of maturity in a female or a male. So let me see where you are and whether or not this is something you know something about. Take a look. The correct order of maturation in males is what? Oh, Lordy Amelie, I don't know. What you thinking? All right, look. Let me give you 2 clues. Clue number 1. It starts low, and it moves up. Clue number 2. When you see it on their face, it's everywhere else. All right? So what's your best answer now? It's number 1. All right, so it's pubic, axillary, then facial. The earliest secondary sexual characteristic in girls, what happens first? And it moves up. What happens in girls first? You were one of these people. What happened first? Breast development. Yeah, TLARC is what it's called. How about number 1? What's your best answer now? The earliest stage of male maturation. Okay, what happens in males first? I'm not feeling the love in here about Dr. Tanner. Huh? Testicular volume, right? The testicles enlarge. That's the very first thing that happens, number 1. So I think you were right. This is not something you feel really strong in. All right, we're going to change gears. Look at my next question. A 4-month-old has an ankle bracelet made of tiny flowers. Have y'all seen that? The baby's mother states that this prevents colic. How should you respond? So listen, you need to expect some cultural type questions on your exam. They'll hit you with something like this, or who knows what it is. Your strategy when you approach any of these questions like this is always to recognize that it's a harmless cultural practice And really, you kind of want to let them do their thing, all right? So I would tell you number 3 is probably a good answer. Suppose this thing, instead of being around their ankles, suppose it was around their neck. Well, we need to have a talk, right? But I'm thinking it's pretty darn harmless as long as it's around an ankle. I really don't think they're going to be able to put their foot in their mouth and eat those flowers. Leave it alone if it's on the ankle, all right? So number 3. Unfortunately, we have to talk about this. Take a look. An NP has filed a report of suspected child abuse for a child she's just examined. Which statement is correct? Well, look at number 1. It says NPs are mandatory reporters, and if you stop reading right there, you're going to miss it. It says in some states. No, you're a mandatory reporter in all 50 states. Look at number 2. It says suspected child abuse requires concrete evidence of abuse. No. If you've thought it, you've got to report it. Look at number 3. Child neglect does not constitute child abuse. Oh, yes, it does, right? Look at number 4 because that's your best answer. And this might not be something that you do, but somebody at some point needs to let the parents know a report is being made, all right? And it may be a social worker who does it. It depends on where you work and what the process is where it is you work. So number 4 is a good answer. Look at this question. An 8-year-old female is brought to your clinic with a spiral fracture. You got the picture? Of the arm. The NP suspects abuse because the mother's story doesn't match the child's story. How should the NP proceed? What should you do? Well, look at number 1. Remember I told you you're going to have some questions on the NP role? Your role is not to confront the mother, right? That's not your job. Child protection can come in and do that. Number 2 says, ask the child what happened. Well, if you read the stem of the question, it said, the child told you some story. I mean, they tell you what happened. An 8-year-old is a pretty darn good historian. So I'm not going to ask her again. Look at number 3. Number 3 says separate the child from the mother. You only ever do that if the child is in imminent danger. Otherwise, if you do that, mom is going to know that you are on to her, and she may bolt at the first opportunity. Number 4 seems like a good way to start this very difficult conversation. A good way to start it is to say, I'm concerned about your child's safety. And then depending on what they say after that will depend on what you do. Suppose they say, well, what do you mean? Or maybe they'll say, because they've been wondering about it and hoping that this wasn't true of their boyfriend, what do you mean? What are you worried about? And I've never, ever found those comfortable to do. Never. We have people who work in PDERs who have to do that a lot. I guess you get better the more you do it. It's just never, ever gotten comfortable for me. All right? So, number 4. Whew. Adolescence. Oh, my goodness. Who has adolescents in here? All right. The American Academy of Pediatrics says that someone between the age of 11 and 21 is an adolescent. They describe 3 different stages during adolescence. This is fair game on your exam. Let me tell you what they're going to ask you about, or what I think they will. Remember, adolescence is divided into early, middle, and late adolescence. In the adolescent brain, different things happen early compared to middle compared to late. In early adolescence, what characterizes it is egocentricity. What does that mean? It's all about me, right? They go into the refrigerator, they pour the last of the milk. Do they tell anybody they took the last of the milk? Nope. They use the last of the toilet paper. Did they tell anybody or replace the roll? No, because they had enough for them. It is egocentricity, right? That's what characterizes it.
What does that mean? It's all about me.
They engage in risky behavior, which gives you a clue about the most common cause of death in this age group, right? They're risky. Look at why they die. Secondary to motor vehicle accidents. They're not driving yet. Look at how old they are. 11 or 14 years. So if you were to get a test question that said, what would be an important teaching point for a 12-year-old who's in for a school physical? You would say, tell them to put on their seat belts, all right? Look at middle adolescence. Middle adolescence is between 15 and 17 years of age. And this is when peer groups become very important to them. Their peer groups And what goes on in there is way more important to them than anything you tell them. When they're at home, they want privacy, right? So they come in from school, where do they go? In their room. What do? Close the door. What do they say? Mom, text me if you need me, right? That's what they say. So don't bother me. I want my privacy. I need my privacy. Risk-taking behaviors begin to escalate, but there is good news in this age. In middle adolescence, instead of just thinking, in early adolescence, they think about the here and now, concrete, that's what they are. In middle adolescence, they improve a little bit. They begin to think about, what do I want to do in a year or 2 years? Do I want to finish high school and go into the military? Do I want to finish high school? What kind of job do I want to get? What do I want to be when I go to work? Unfortunately, though, risk-taking behaviors escalate, and so when we look at the ages, most likely cause of death during adolescence is motor vehicle accidents. The age group, very common, 15 to 17 years of age. They take risks, right? And then finally, in late adolescence, this is where they usually have a best somebody, right? Emotional intimacy develops. We begin to see an increase not just in motor vehicle accidents, but suicides and homicides, all right? So the cause of death begins to change in late adolescence. And so, thankfully, they get out of this stage. What about anticipatory guidance with adolescents? Man, do you have a lot to talk to them about, and really, it's worth the 5 minutes that it may take of your time, because you might be the only person who ever talks to them about some of these very good habits, about what they eat, about what they sleep, who they hang around with, the kind of activities they engage in. Please have that conversation with them. Immunizations, they might need a lot when they see you, so assess that always. And we need a break. Take a big, deep breath. Let's check your knowledge and see where you are. A 12-year-old female visits ENP because she has asymmetry of her breasts. She's at Tanner stage 3. What do you know about that? Are you worried, first of all? Her breasts are asymmetrical. I'm not worried. What are we going to tell her? Don't worry, it's going to resolve by Tanner stage 5. Suppose this were a male. His breasts are asymmetrical. What do you think? It could be gynecomastia. Listen, if a male has asymmetrical breasts, I'm still not worried. Tanner stage 5, they'll be equal. You need to write next to this question, gynecomastia, because I think you're going to see a question or two on the exam about it. If you don't know anything about it, go read, but there are a couple of drugs that immediately come to mind when I identify gynecomastia in male. First of all, obesity, right? But 2 drugs, what are they that can cause gynecomastia? Pot. All right. I guess it's a drug. What else could I call it? What's another one that they might take? Tagamet, cimetidine, right? So watch out for that. Somebody mentioned aldactone. That's true. A lot of drugs can do it, but the point is, when you see it, you need to think about and begin to investigate why might they be having this, all right? Okay, so look at this. When a 2-week-old infant has white pinpoint papules on his face and cheeks, what is that? Milia, exactly, number 3. Which finding is abnormal in a 2-month-old child? Well, I'm really worried about our closed anterior fontanelle, right? Number 1. The other 3 are all normal. In most children, the primary teeth have completely erupted by what age? 24 months, exactly. So by 2 years of age, they should all be out. Normal vision, when is a child expected? 6 years of age, 20/20, right? All right, listen, I'll put some extra material in your book because a lot of people across the country are very weak in pediatrics. I've given you some information there on growth and development. And if you turn the page, there's also something there on anticipatory guidance. If this is a very weak area for you, I think you should review it. And people tell me that when they review that, they zoom through any of those questions that they might have.